Okay, I think we should start. Hopefully people who are having coffee will finish up pretty soon and take their seats. So welcome to this session. So this is a session that we put together to really, we did this in Budapest and it proved to be quite popular. So we've repeated it again for this meeting. And it's really to address some of the very complex issues that we face as clinicians and practitioners. We deal with cases which are often not straightforward, and there are no specific rules, as it were, as to how we move forward. And it can cause complications, it can cause discussions amongst our medical teams and multidisciplinary teams as to how we manage these difficult cases. And it was really about the ethical issues rather than specific medical issues that we want to address. And so what we thought we'd do was highlight three cases, and these are all real cases that we've encountered at our institution, but I'm sure they're very, very similar to what other people have encountered in their own practices. And I'm going to ask my colleagues here to offer their opinions as to how they would look at these issues and how they would take them forward. So we have Carla Duff from Florida, who's a nurse practitioner. We have Bruce Lim as a patient representative. Bruce is from the Malaysian IPOPI, from Alain Fischer from Necker, an eminent pediatric immunologist, Josie Drabwell, our chair of IPOPI, and we also have James Taylor here, and James is a philosopher specializing in medical ethics, and hopefully James will make some sense out of the nonsense the others will have talked about. Okay? So
I haven't even said anything yet.
Okay, so we'll look, and what I hope to do as well is also get your opinions. And so please, this is meant to be an interactive session. So once the panel have had a chance, and James, then it would be great to have your views as well and your thoughts on some of this. Okay, so this is the first case. And I'm going to read this through, and these are also available on the screens as well for you to be able to look at. And as I read through, you'll be familiar, I'm sure most of you will be familiar with this case and where it comes from. So 6-month-old child diagnosed with a very severe, undefined immune deficiency, so has been looked at and no specific defect has been identified. The damage to the child's brain and other organ systems make the child unfit for any conventional procedure. And the physicians advise that the palliation is really the only course possible. The parents have found a doctor in another country who has an experimental stem cell therapy that he says, this is the other physician, may be able to help the child. It has not been used in a condition such as this particular child's, but he has tested it in mice. The parents are very keen to try this experimental therapy and have also raised their own funds to allow them to take the child to the country where the experimental therapy can be carried out. They're very keen to proceed with this, but the physician's view is that this is futile, untested, and could result in potential harm. And they resist the parents' wishes for the child to receive this therapy in another country. Now, you can see that what I've just put together here is the Charlie Gard case that created international headlines when this child with a neurometabolic disorder at Great Ormond Street wanted to go to the US in order to access therapy. But the case is pertinent to many other disciplines, and we have faced cases before where it's felt there are differences of opinion between what the parents want and what the child and what the physicians want. And so we thought we would explore this. Now, as you know, the Charlie Gard case excited many reactions and opinions, and we did ask Donald Trump whether he wanted to come here to offer his opinion on this case as well, but he's in North Korea and he said politely declined to come. We also asked the Pope, but he declined as well. Okay, so in fact, we just have our panelists rather than Donald Trump or the Pope. All right, so this is the case, and so I'm going to start. And so, Carla, would you like to start off with your thoughts on how this could be handled?
So my first thought is parents will do anything to help their child. And you won't always be able to say, I did my best, I did everything. So from a nursing perspective, I think the biggest thing is to make sure you discuss with the parents the pros and the cons. If they go and have this experimental treatment, this child may die. And parents need to know that, exactly that, this child may die. And also, if you come back to the US after you've had this, it may inhibit his care in the US or what other country you're from, and we may not be able to give him any additional care that he needs due to the stem cell transplant. So I think it's really important to lay out the pros and the cons for the parents, but ultimately, it's a parental decision, but I would make sure that was really clearly documented.
So you're saying there that it is the parental decision?
Mm-hmm. Yes.
And you think, actually, so are you saying that you think the parents should be able to take this child to access that therapy?
I think the parents have that right, but I think that should be clearly documented in his medical record that there was a discussion, the parents were educated, and against medical advice, they're going to do it anyway.
Even if the duty of care that the doctors and the clinical staff have is to the child, and they think that actually this may cause harm to the child, should they not speak on behalf of the child and resist the parents' attempts to take the child to the other country?
You absolutely could. In the US, we have medical foster care, where we could go and say that this is we'd bring it to our ethics board and say this is an ethical dilemma, and then we'd like to put the child in medical foster care and have a guardian ad litem for the child so that there's someone speaking on the child's behalf, and it's not the parent's decision.
Okay. Bruce, what are your views on this?
In my opinion, when you exercise palliation by the physician, it's actually leave no other options for the parents. I'm talking from the parents' perspective, whereby for the parents, they would like to find hope for the child. Therefore, they would go for any therapy or experimental therapy which is a hope for them. In my case, my own experience, when my child was diagnosed at 4 years old with XLA, although it is not an emergency case or like this, but at that time, I am as a parent ignorant of what is XLA. I thought it is really serious. But my physician at the time is a renowned pediatric doctor in Kuala Lumpur. And my child's file is that thick. And she just closed the file and said, "Sorry, Mr. Lim, I cannot do anything else for your son." So if you as a doctor cannot do anything else for my son, what more? I as a parent. So you leave me no choice but to seek other options or other alternatives.
But would you take your child even if the chances of that other option was futile, had not been tested, could cause harm to the child? Is that the right thing to do, to take your child for something like that that's completely unproven and could be harmful to the child?
Well, it is a calculated risk as a parent to weigh the option that I have. But at the end of the day, I think respect of autonomy of the individual is here. Is the main topic here.
But that should be the respect of the autonomy of the child rather than of the parents. It's not that case?
But at the time, the child is only 6 years old.
Yes, so...
6 months.
Okay.
My case is only 4 years old.
Okay, all right. Alain?
Well, two things. First, to mention one case I've been aware of typical experimental therapeutics that has been tried because of the wishes of the parents. I became aware, that was maybe 20 years ago, 15 years ago, of parents, several, from Israel with patients with ataxia telangiectasia, and they became informed that someone in Russia was proposing transplantation of embryonic stem cells in the central nervous system to try to correct the neurological defects. So the children, went to Russia, got the transplant back to Israel, and then in Israel they developed tumors. These cases have been published. So these are typical examples of what you are putting here. Sorry, closer to the microphone. So that just to say that it's not only theory, this exists in reality. So we are talking about experimental therapeutic. And in my view, I think things should be simple. To me, if there is an experimental therapeutic, it means that the PI, the investigator, has the money to cover all of the costs. So in any case, the family does not have to pay anything. So if someone somewhere proposes a therapeutic but has no way to cover the cost, it suggests that this person, well, of course there may be exceptions, but this person didn't get the funding, and since the person didn't get the funding, it's perhaps because the scientific basis is limited. So I think it's a good, to me, it's a good criterion to go ahead or not. But of course, eventually, you can't block a family to go, say, in Russia for, I'm nothing against Russia, it's just an example, to get a crazy treatment, that you can't block it. But to me, in principle and ethically speaking, any new therapeutic that is being tested should not be paid for any cent by the parents.
Right. Okay. So the cost issue was really more about the parents having the finances to take the child, to be able to sustain themselves while they were there, rather than paying for the therapeutic itself. So if we take that aspect out of it, I'm going to put you on the spot here. What would you have done here? Would you have let the parents take the child for this experimental therapy, an untested experimental therapy?
Two things. Well, I don't think the money issue is marginal, because it says something about the therapeutic itself. It's not only per se the money, is that it suggests this is not something which is really to be considered. Now, of course, I will not accept it, but of course the parents can go without my permission, that's for sure.
Even if the child could come to some harm and you think it's completely futile?
I am against it.
Right.
I will tell the parents very firmly that you should not go, but then I am not a policeman, so I have no way to prevent it. But I will do everything I can to convince them, take time, and suggest to the parents to talk with several people, including people from other centers, abroad if necessary, before they take their wrong decision.
Okay, thank you very much. So, Josie.
I have to start by saying that this is not my opinion that I'm going to share, but I'm just going to say something that hopefully will provoke a reaction from all of you so that you join in the discussion. Now, this Charlie Gard case, for example, this is not a unique case. There are about 18 per year, I believe, in the UK, and most of them get to go to court, and the child gets appointed a guardian. So the parents are represented, the doctor is represented, and the child is represented. And in this particular case, it was a journalist friend who brought this to the attention of the public. And as a result, the parents managed to raise, I believe, over £1.3 million to have this, the baby treated in another country. And I have to say that if I was able to raise that much money, and it was my only child, and this child was so ill, I would take it wherever they offered any hope of treatment. And even if the doctor said, yes, this child might not survive, but the child was not going to survive anyway, so is it not worth trying?
Okay. So actually, the opinion seems to be from all four of you that you would allow the parents to take the child to access the therapy, which in fact was the opposite of what happened in the UK, where the family weren't allowed to take the child, and it became a legal discussion, and the law sided on came down on the side of the hospital in preventing the parents from taking the child to the States to access the therapy. So, okay, so that's very interesting, your perspectives on that. Josie.
But I was just highlighting it because the other 17 cases that never get to go into the public eye, you know, that is, the decision is made on good sense and good judgment. So I am just saying that the whole case was so influenced by the media, who hyped it up to such an extreme that you had, even the nurses in the intensive care unit were receiving death threats for treating this baby.
Yeah.
I mean, how ridiculous is that?
Yeah.
You know, and there was this nurse saying, you know, whatever she did, she only cuddled and cared for this baby, yet she was vilified for looking after this baby. Now, this is only media, and this is so wrong.
No, then that's another issue that we can talk about. But okay, so James, do you want to wade in here from a kind of ethical perspective?
Yes. Is this on? Can I be heard? I'm loud and obnoxious anyway, so the microphone's probably irrelevant. So I'd like to start by noting that I'm listed on the program as Dr. James Taylor, and that's accurate. I do have a PhD, but I'm not a medical doctor. I'm a moral philosopher, and I have a great deal of respect for people in the healthcare profession. I actually think that none of you are paid enough. You should be paid much more. And people in the healthcare profession cure people of physical ailments. You make other people's lives flourish. This is wonderful. And my doctorate also allows me to cure people. I think that I cure people of muddled thinking and poor reasoning. And muddled thinking and poor reasoning can also cost lives and lead to people's lives going much worse. So I think that I do something important as well. And on my name tag, it's listed as ethicist. And I noticed at the reception last night that when people saw this, everybody tended to veer away from me because we're not quite sure what an ethicist is, but we're pretty sure we want to avoid it. And my response to my fellow panelists might actually confirm your aversion to me. So for dinner tonight, I'm going to be just as lonely as I was at the reception last night, because I think that they're all actually mistaken. And I'll go through why I think they're mistaken, and then make myself deeply unpopular with everybody on the panel and in the audience, and probably throughout most of the Emirates. So I think both Carla and Bruce were focusing on a very natural and a very human response to this case, namely that parents would do anything to help their child. And for Carla, it should be a parental decision, and for Bruce, it should also be a parental decision, so long as there is hope. A view which was also echoed in some part by Josie, although Josie made it very clear that that's not her opinion. We're not quite sure what Josie's opinion is. I suspect it's probably quite wicked. But I think that this is mistaken because we can cash the case out in terms of persons' moral rights and the moral claims that people have. And I think that Carla and Bruce are correct that parents have a considerable array of rights over how they raise their children. They have the right to raise their children in a particular religion that they adhere to. They have extensive rights over the type of education that they give their children, and so forth. But I think that parental rights are actually limited, and they're limited by consideration of the well-being of the child, because I believe that children also have rights. Often, the rights of the children and the rights of parents tend to intersect. Parents are genuinely concerned for the well-being of their children and act upon this, and the rights of the children are not violated or undermined in any way. But occasionally, I believe that the rights of parents and children can actually come into conflict. And I believe that persons have fundamental rights to healthcare, to living as flourishing a life as it is possible for them to live. And most fundamentally, they have a right not to be subjected to needless and pointless suffering and harm. And I think that this case shows rather clearly where a natural human empathy for one's child might actually lead you to a course of action which could actually be to the detriment of the rights and the interests of a child. So as the case is outlined, the medical treatment that the parents are intending to seek is considered by the attending physicians to be one which is futile and might actually lead to suffering of the child. Given this, I think that the parents' rights don't extend to essentially subjecting the child to a further course of treatment which is unlikely to be successful and which is going to extend or worsen the suffering of the child in question. Think of it this way. Imagine that I have strange Scottish views concerning raising of children. And so this example might resonate quite heavily, that I force-feed my children haggis every morning, pounds of haggis forced into them because I believe that it will make them strong and vigorous. And the amount of haggis that I'm forcing into them is enormous. It's 15 pounds for breakfast, 10 pounds for lunch, and 35 pounds washed down by at least 2 bottles of whiskey for dinner. This is clearly appalling, and I ought not to be allowed to do this. Now, this is admittedly a frivolous example, and the Charlie Gard case and others are heart-wrenching. But I think that just as I ought to be restricted in how I treat my children, even if I'm doing it for the best of intentions, so too should parents also be restricted in how they treat their children in these particular medical cases. And Bruce raised something, and it was echoed by Josie, that I think is it resonates very heavily with everybody, that if there's hope, shouldn't you try for that hope? And that, put bluntly, seems very appealing. But let's imagine that there is hope, but it's a 1 in 10 million chance. And the treatment is thus highly unlikely to be successful and would exacerbate the child's condition so that the child is in constant pain if the treatment is unsuccessful. There, I think, we're imposing significant harms upon the child for what is essentially a very, very tiny sliver of hope. Most of us don't make our everyday decisions on the basis of tiny, tiny risks. And I think that we ought to safeguard the rights and well-being of children in these cases, even though we can sympathize greatly with the plight of the parents within them. So, to put it bluntly, I think that most of the panelists are mistaken, and I think that the actual approach taken, which is to restrict the parents' ability to do as they wished with their child, was actually the correct decision to take.
Okay, James. Well, thank you very much. That's very clear as to what you think. So that's excellent. I'm going to give the panelists some right of reply to that. Who would like to respond to James's view, having said that you're all completely mistaken? Bruce.
I would like to point that the fact that the second line you read that the damage to the child's brain and organ system. I mean, that is already a diminishing hope for the child. And I think as a parent, why not gamble?
Right. Okay. All right. Let's take some views from the audience. Who's got? Okay. There's one.
Although I'm sure that it is not intentionally written in this way. But anybody that reads this story will answer immediately no. But let me just give you an example, real from the practice, that a consanguineous family that lost the first baby because of undefined immune deficiency, though the genetic study is done. The second baby, when it comes to the third baby, he's fortunate that the mom is compatible, the diagnosis is undefined. But we go for transplant, and he is at school now with 8 years old, and he's very happy.
So, sorry, I just want I didn't quite get
That what I understand from that, maybe I understand it wrongly, but you know that because of undefined immune deficiency, undefined diagnosis, you might find it difficult to go into a procedure that is not approved.
Yes.
But this is definitely true. But in the practice, sometimes you are obliged to go for something that if these tragic findings that happened in the family, in the first baby and the second baby, and you still are unable, even with sending this patient to reputable centers, going for genetic study to help or to justify for yourself to go into a definite therapy that like transplantation. But what's not happened in this case, where we are obliged to go into a transplantation for this third baby with compatible mother, and the result is very fruitful.
Sure, but in the case that you're talking about, the treatment that the child had is a conventional treatment. It was a transplant, whereas what we're talking about here is an experimental therapy that hasn't been tried before. So there is a difference as to what the child you're talking about received and the scenario here. But thank you. Alain.
Yeah, just like maybe to reiterate a little bit with other words what I said, that is the ethics viewed as not at the level of the child and the parents, but at the level of the society. That is a futile, so something which is considered futile as a medical procedure should not just not be allowed, should be forbidden, should be impossible to practice. So I think this is the responsibility of our societies to define the ethical criteria. To allow or not to allow potential innovative
which is why we have clinical trials.
If it is fertile,
it is exactly why we have clinical trials.
If it is fertile, it's fertile. It should not be performed anywhere.
Okay, exactly. And I think that's one of the issues that came around here, is that this was not in the context of a trial, it was not in the context of a therapy that had even got to the point of being used in patients with this disease. So, okay. Any other, yes, so is that... Klaus, yes. Good.
I don't shout.
You don't have to shout now.
So the question, was it futile or not futile, is a very difficult decision. And I think the case is, I don't know the case, but I think the way it is presented, it seems futile. And I understand that. But I do think the decision...
Most likely to be futile. I suppose. How can we say it is going to be futile? Right. It's most likely to be futile, untested, untried.
The point I would like to make, I think the decision whether such a case is futile or not should not be taken by one person. Correct. I think this is clearly something in my eyes which should be put in front of several experts and discussed with the experts to make that decision. Because I worry that the first heart transplant was probably considered futile too, and you're not sure whether you should go that way or not. So I think there's always something which we may not actually consider as being successful. And I agree with this case that it's very unlikely to be successful. And I agree with what was said on the foresight. So I think I'm still on the people on the foresight. So I do think that there is something which needs to be considered, and therefore I think it needs to be discussed in an expert group in such a case, and I would not like to be the only physician taking the decision to say, sorry, this is really not reasonable.
Okay, yeah, and I'm sure, and I know from, in this case, at Great Ormond Street, it was discussed extensively with other, it wasn't just the treating physicians, but second opinions and wider opinions were also taken before decisions came to. I think we'll have one more, there's so many hands. Okay, Josie?
Yeah, I think that the case in England actually, went before a judge and a court. It might have been in front of the expert as well, but what caught the headlines that it actually went to court. And I think that is perhaps not the right place for those decisions to be made.
I think that's very true, and I think it's also what caused the inflammatory environment around the discussion of this case, that now there was a legal block to this rather than a discussion between the parents and the friends. But it got to that point because there was an impasse between what the parents wanted and what the physicians wanted. Okay, I think I'm going to take one more from Antonio here, and then we're going to have to move on to the next case. So, Antonio, have we got a microphone? Sorry, Laura. Sorry, I didn't see you there.
Well, it's just a quick question. So let's suppose that the parents eventually went to the experimental therapy. It's a bone marrow transplant. And after a couple of months, things were apparently going well until this child developed some complication related to the transplant. For example, severe graft versus host, or a leukemia, or something very bad about the transplant. And this child came back to Alain Fischer, who is the doctor in charge. Alain, what would you do? How would you handle this family? Because you were very positive with them. Listen, I do not support this decision. It looks like crazy, this treatment. So what would you do for this family now? What will you...
I will take care of the child. That's obvious.
Yes,
the,
exactly.
the right of the child is first, is the priority. So if the child is suffering from that treatment, of course, I will take care of the child and do my best to to solve the problem. In the example I mentioned about the brain tumors in ataxia telangiectasia patients from Israel treated in Russia, I know that the people who took care of the patients, they did surgery to remove the tumors. That's obviously in Israel. That's obviously what had to be done. I mean, of course, the poor patients, they are not responsible of anything, and they have to be treated as with the best standard care possible.
On this second point, I think we're probably all in agreement. Okay, well, thank you very much. I think we have to move on to, because we've spent quite a lot of time on that particular case, and we've got two more. So we're going to go on to the next case. And again, this is a real case from our practice. And so let me just read that through and hope you can see it as well. So a 10-year-old boy is referred for a bone marrow transplant following a history of recurrent infections and recurrent and severe infections, and also immune dysregulation manifestations. Genetic diagnosis is confirmed and available and is a condition that has a poor prognosis. So we know that this is going to lead to a poor outcome in the long term. Bone marrow transplant is recommended by the clinical team and a suitable donor identified. Parents are also keen for the transplant to take place. However, during the care of the child leading up to the transplant procedure, it becomes extremely difficult for the clinical team to care for the child because of the obstructive nature of the parents' interactions. The parents obstruct the child's care on a continual basis. They refuse blood tests, they question when blood tests are being taken, they question prescriptions, they don't allow certain investigations to take place, x-rays, line insertions, etc. Mediation and negotiation is attempted on a number of occasions. So a number of conversations were had with the parents to say, we need you to behave in this way. But even when the parents agree to specific rules of conduct that will allow optimal care, they soon revert to previous obstructive behavior. The treating team is not keen to undertake the transplant, knowing that this is a risky procedure, requires significant investigations and interventions, and needs parental cooperation in order to go through the procedure. Meanwhile, the child's condition continues to deteriorate. The other complication is the child has been referred from another country where expertise for bone marrow transplantation is unavailable. So what should the team do in this situation? And I've put a few discussion points underneath that, which you can see. Is it appropriate to undertake a transplant knowing that the parental behavior could compromise the safety of the procedure? Should they assume guardianship of the child, if possible, given that the child comes from another country, exclude the parents and undertake the transplant? Should they refuse to undertake the procedure and send the child home knowing that the prognosis is likely to be very poor? Okay, so I'll start in reverse order. So Josie, what would you say about this one?
Okay, again, not my own opinion.
You're really sitting on the fence here, aren't you?
Well, I would say that the parents must have known before they came to the other country what was involved. And if they're being this obstructive, then obviously any medical treatment that this child is going to have is going to be not improving by the parents' disapproval. So I think I would send the child home.
Okay, what? And let him suffer? Let him succumb to this illness?
Not her opinion.
Okay, Alain, I don't know whether you've come across this before in your many years looking after patients. What would you do in this case with such obstructive? And let me just say, we tried on numerous occasions with this family to say we have to have your cooperation. We have to have to be able to do these tests. And on each occasion, they started and then they refused, and it was back to the same circle of events. So
we have also a few cases of similar experience, including patients from France.
Yeah.
So it's not always just an intercultural difficulty.
Sure.
It could be even more complex that I have in mind, at least a recent case like that. Again, I think this is a situation where there is a contradiction between the child's rights and parents' rights. Yeah. But the difficulty here, to me, is that these things are not independent. They are completely interdependent, since we know all of us who perform bone marrow transplantation know that without the cooperation of the parents, it's not going to go well. So at the end of the day, if nothing works after hours and hours and hours of discussion and trying to have mediators, everything you did and you mentioned. If it eventually doesn't work, I will probably not perform the transplant.
Okay, okay, all right, very interesting. Bruce.
Well, I think at the end of the day, you have to respect the parents' consent. When the parents has given the consent to go ahead, I think it's a moral duty of the physician to proceed.
But even if the parents are obstructing the path of treatment, so that it actually, okay, the parents say, yes, go ahead. But then when you say, I want to do an X-ray, I want to do an ultrasound, I want to do a CT scan, or I want to take this blood test, they say, why are you doing it? No, you can't do it. Can you not do it another day? No, I don't want you to do that this week. He's had enough blood tests already. Do you continue with that? Because it puts the child at risk, you see, because you can't do the things that you would need to do in order to look after the child properly. Do you fight with the parents at every step?
Well, I think you have to consider why the parents is obstructive. Is it too frequent of blood tests that makes the child go haywire every time? Because it hurts the parents to see the child cry, or whatever it is. But for me,
and we went through all of that. So we went through all of that. We'll do the blood test less frequently, but then even then it was too much. We said we would do it slightly differently, and even then it became obstructive. So, and this happened over and over again.
Then pull the parents aside and counsel him.
Yes, and that was tried as well, and then we fell back in the same cycle. Yeah, Carla.
All right, so I have a different opinion. So for this child, transplant is necessary for life. This is truly a life or death situation. If he doesn't get his transplant and we send him home, he's going to die. So what no one has said is ask the child. This child is 10. That's a legal age of consent in my country. No one's asked the child what the child wants. Does the child understand the risk and benefits? And if this child wants the transplant, I say you go to court and you take guardianship of this child. I know that sounds very abrasive, but this is truly a life or death situation. For this child, we actually had a case like this in our practice. The child was referred to us from a different country. The parents came, they had raised the money to come to the US, they wanted the transplant. Then I don't think they understood what that really meant.
Right.
Because once we started doing all the things you need to do for a transplant, they were like, we can't do this. So we said to them, it's life or death. And they said, no, we want the transplant, but we don't want all of this.
Yeah.
You can't have one without the other. So we actually put the child in medical foster care. Somehow this child that was from a different country actually got government insurance. Don't know how that worked, but he did. So we put the child in medical foster care for his first year. So for the 100 days post-transplant, and then...
And you excluded the family from...
The family was allowed to visit, but they were not part of his medical care. He
Right.
was put in medical foster care for the first year post-transplant, and then he was released back to his parents.
Okay, James.
I think this is where I make Carla happy and my other fellow panel members unhappy, and every parent in the audience, including myself. Well, actually my daughter's view is, but if there's any possibility of me not making decisions for her, that would be good. But most other parents, deeply unhappy. So, Josie claims that this is not her opinion, and I can see why she's trying to distance herself from that particular opinion of sending the child home to die. That's your view, isn't it, Josie?
It's not my view.
Not Josie's view. So she claims. And Alain would not transplant, and Bruce would focus primarily upon the parents' consent. And I think that again we see an issue of a conflict between the medical rights of a child and the concerns of a parent. But it's a little bit different from in case one, because here recall that the parents are actually engaged in some mediation and negotiation with a medical team. And it seems that they do actually agree to specific rules of conduct which would be successful, but then they quickly revert back to their obstructive behavior. So it seems that the parents really do want what is best for their child in this case. And they have some understanding that what they want, as in Carla's case, is for the transplant, but they're not medically aware enough to know that all of the additional medical procedures are required for a transplant to be successful. So it strikes me rather that the parents are, in this situation, rather like Ulysses, when he's about to sail close to the sirens. Ulysses, as everybody will recall, wanted to hear the sirens, but he didn't want to be driven mad by their beautiful songs and throw himself overboard. So he instructed his crew to strap him to the mast so that he could listen to the song, but the disadvantageous effects of the song wouldn't actually come to him. I think that the parents are rather like this. They are, as moral philosophers would say, rather weak-willed. They know what the best course of action is to have the medical procedure performed on the child, but they're pulled away and they're distracted and they become obstructive. So to serve both the parents' interests and the interests of the child, I would also advocate, as Carla did, for medical foster care or medical guardianship, on the grounds that in the long term, this is actually going to serve the parents' interests, and it's also going to serve the child's medical interests. Now, somebody like Bruce might say, and I'm not attributing this view to Bruce, but somebody like Bruce might say this. Bruce is looking worried. But, well, the parents' view should trump. That's an unfortunate choice of words because it has unpleasant connotations. Parents' views should take precedence. And I think that's mistaken because imagine this. Imagine that we have a situation where the child is actually in foster care and comes needing this procedure, and then out of nowhere, the estranged genetic parents appear on the scene. I would think that those parents would have no real moral claims to be directing the medical treatment of a child. Imagine a separate case, that the child is grown up in a loving family, but not with his natural parents. He's with, say, perhaps neighbors or perhaps extended family members who love and have deep concern for the child. In that case, the mere fact that these people have deep concern for the child, I also don't think really gives them any particular moral right over the child's medical treatment if their deep concern for the child might lead them to make poor decisions. So, given that I think that the focus really should be on the patient in medical situations, and in these cases the patients are children, I think that the expertise of the healthcare profession, not a single individual, but a broad panel of healthcare professionals, should take precedence over the concerns of the parents, and we should move towards some sort of medical foster care or guardianship to ensure that the procedure could take place and the best interests of the child, and in the long term, the parents are truly served.
Thank you. So, Alain, can I just ask you about the issue of guardianship, and would you go down that route? Have you thought about going down that route in cases that you've dealt with?
Yeah, we discussed that a few times. We never went to that extreme. Actually, it is absolutely exceptional that at the end of negotiations, including involvement of other people, that it's not possible to raise a kind of compromise, quote, acceptable for the healthcare professionals as well as the parents, so that fortunately this is not that bad. But I am a little bit hesitant or almost perhaps reluctant to go to the foster care because practically speaking, to undergo a transplantation to a child with the parents having lost responsibility, so they are there but they have nothing to say, it seems to me. First, it's very violent. Of course, you can argue that not to treat the child is violent too. But it is very violent, and I don't see how it could go very well with, quote, silent parents, in the case parents are actually not silent. So practically, I understand the theory. It, of course, it sounds good, but practically speaking, it looks to me not that easy to implement.
Yeah. Josie, you wanted to...
Yes, of course, not knowing the background to this case, was it perhaps possible that there were cultural differences between the parents and the doctors, and also had the child expressed some reservation himself?
So there were cultural differences, but then we were looking after parents and families from that part of the world, in many, many times as well. So it was not cultures that we were not accustomed to, as it were. So, and the child wanted to go ahead with the transplant. He was keen to go ahead with the transplant. And Bruce, and before I open it up, yeah.
What the panel was speaking about is, in a developed country, you have law in place whereby the 10-year-old child's decision-making is taken into consideration. Let's take this into our developed country perspective. And especially in our country, the government are encouraging medical tourism. So let's put it into Southeast Asia, for example. If these parents coming from Indonesia and doing the procedure in Malaysia, say, bone marrow transplant, we have a success in Malaysia. How can we talk about these laws in place? I mean, I'm open this perspective to the floor. Maybe there are doctors here from our region can.
Okay. Well, let me open it to the floor. So, Laurie, yeah.
Thank you, Bobby. So my name is Laura Marquez, and I come from Porto, in Portugal. And we have their immunodeficiency unit, pediatric immunodeficiency unit, and an adult. I'm in the pediatric unit. And what I would like to say is really common sense. What I think we need to invest in is in the prevention of these cases. Because doctors and all the healthcare team want the best for the patient. And they try to do the best. And parents as well. So the first thing I would try is to understand why did they become obstructive? Why? There must be reasons for that. And we have to really invest because we are so busy, trying to do it fast, trying to do it well, and sometimes we don't give the time and the environment suitable for the parents to express their doubts that they may think they are stupid, but that they are there and they are causing these manifestations. And what we do in my team is, I always talk with parents as the responsible, but I also call for nurses that have a very important part in this, because sometimes they can figure out why are they obstructing. And also with other parents. We are here in the IPIC, and parents associations are very useful, because if they come in contact with other parents that had similar situations, they can perhaps become more trustful and understand the procedure and why these nasty things are being done, because we want the child to survive. And my experience is that if we invest in this area, we don't have these cases, because when it comes to court, all is lost, because everybody is angry, and the child's interest may be harmed.
Thank you for that perspective. Let me, yes, Waleed. Yeah, so one here.
We occasionally face such issues, and the way we deal with it is that we involve other family members, like uncle, auntie, grandparents,
right,
who can mediate the negotiation between us and the parents. The parents, sometimes their vision is not clear. Having an independent other person who is caring for the child and who can understand us, better, because the parents are overwhelmed with the whole situation. So I think involving other family members, other than the parents, is really helpful.
Yeah, thank you. And in fact, in other cases, we've tried to do that. In this particular case, because they came from another country, there were no other family members available to take on that role that you suggest. I think we'll have one more, and then we'll have to...
Yeah.
Yes.
What I would like to say is in line with what has come from the floor from the other delegates who have spoken. It seems that optimum communication has not taken place between the treating team and the parents. And since it is a child who's already gone through a lot before he has reached this stage, definitely that would have been what happened. And secondly, because they are from another country, which, as has been pointed out, could be a lot of language and cultural barriers. So it seems that the treating team has not done enough. Communication has not been optimal, and they have not made an effort to make this family meet with another family who had a bone marrow transplant done and whose child is thriving well. So before they would think of foster care, I think there's a lot that the treating team have to think about.
Right. Just in defense of the treating team, I can tell you that a huge amount of effort went into trying to address all of these issues about communication, about explanation, and hours and hours and hours were spent talking to the family to try and understand what the issues were. But it all still came back to these problems. I think we're going to have to move on, because otherwise we're going to... okay, one more final quick...
Foster care. Bobby, I just wanted to say...
Very quick. I was just wondering what place does the relationship between the child and the family what place does it take, I'm sorry, in the treatment itself, in the success? Because it's difficult to me to think of a child being separate from its parents, and that must have an impact on the treatment itself.
Mm-hmm. So in our case, actually, the mother willingly placed the child in medical foster care. She understood that she was inhibiting his health. So once it was explained to her that if he went into medical foster care for this period of time, he would get his transplant, he would be cared for, and she would still be involved, she willingly placed him in medical foster care. We didn't just take the child from the family. We discussed that if we were going to proceed with the transplant and save his life, this was our only option. So the mother willingly agreed to do that.
Okay, thank you. Okay, thank you very much. I think we're going to have to move to the final case. We've got about 10 minutes left. Okay, so this is slightly different, and is again a real-life case. So a 22-year-old woman with periodic femur syndrome was referred from rheumatology to the pediatric immunologist after a mutation in the Wiskott-Aldrich syndrome gene was identified. So this is a woman who is having a defect identified in the Wiskott-Aldrich syndrome gene. She had no features of an immune deficiency, and there was no family history of Wiskott, though interestingly there was a paucity of males in the family with no boys born in the last 5 generations. So you can't tell whether this mutation in previous family members would have led to the disease. Little is known about the mutation, so we can't tell whether it's a disease-causing mutation or not. It has been described in the normal population, as well as in a couple of patients with severe Wiskott-Aldrich syndrome, in conjunction with another mutation that is usually associated with a mild phenotype. So whether this mutation actually causes Wiskott is not absolutely clear. However, immunological tests were normal, including expression of the protein, and the conclusion was made the mutation identified was unlikely to be causing her inflammatory symptoms. It is possible, however, that she has been coincidentally found to be a carrier for a significant Wiskott mutation that could be passed on to her children. So the discussions here are what, when, and what to report to patients about variants of unknown significance, particularly before a definitive conclusion as to whether this is pathogenic or not has been reached. With this uncertain significance of the mutation identified, should there be any further follow-up of this individual? Should she be come back for repeat tests? And should she be screened for future complications such as malignancy in the event that the mutation is actually significant? And should future children of this woman, should they be tested antenatally in case this causes a problem? Okay, so it's really about the fact that this is a mutation where we don't know whether it has significant consequences, and how do we manage that? Okay, so let's, Carla, do you want to start?
So I think I would tell the patient that we have found a mutation. We don't know what it means, and we need to do more testing, because I think it's the patient's right to know she's an adult, and if you don't tell them, they're going to ask anyway, and they're going to keep asking you. You drew my blood, what did you find? Did my test results show anything? So I think she has the right to know that we found a mutation, but we don't know what it means yet.
And so you feel happy to give her information, even though there's significant uncertainty both for her and for her future children as well.
And I think we would explain that to her, that we don't know what this means. We would probably still see her in clinic, do some more testing. I would recommend genetic testing probably, but I think she needs to know so that she can plan for her future as well. And then two, we could also say we have colleagues who might be able to help us. We'd like to send your blood here, or we send your blood there. Do you give us permission to do that? Without having a conversation with her about her potential diagnosis, we can't ask her to let us ship her blood to a different country, to a different center, to try to find out a little more.
Okay, thank you. Bruce.
Well, I think open communication is essential here, also in a timely manner. Well, the patient has the right to know and why it needs to be referred to another team or further investigation. But then again, in developed country, we have those factors like socioeconomics and low educational level of in our countries. So some instances, I think the doctors make the decision for the patient. Well, I'm just throwing out this scenario. So it does happen that some doctors make the decision for the patient without even communicating this.
And so you're saying that that's wrong. They should. I'm
asking the question: is that okay?
Okay, Alain.
I think there are two issues here.
Okay.
One is uncertainty about the disease, so related to the test. So in that case, in order to proceed, there is no discussion, or every single information has to be given to the patient and to be explained with the time necessary to make sure that the patient herself understands what's going on. So for me, there is no doubt. But then there is the second question are the issues of incidental findings. And I think which of course could be very serious in some cases. And I think for the incidental findings, this has to be set up a priori. That is, before initiating the genetic test, this will be discussed with the person, the patient, whether she would like or she will not like to get additional information. In other words, she has the right to know, but also the right not to know.
No. So, yes, so before they were testing for whatever, it's clear that there is a possibility that another disease or mutation or variant might be identified. And would you or would you not want to know about these other entities? Okay. And Josie?
Well, yes, I have to agree with Alain because, you...
Is this your opinion or is your...
It's my opinion.
Okay. Just wanted to establish that.
Yeah, finally my opinion. Well, as a patient, I would like to know, what's going on with me. So I no doubt after I was, being told that, yeah, hooray, we found something, but we don't know what it is and we don't know how to treat it. That, of course, is a bit of a problem. And no doubt I would hound you every day, say, have you found something new yet? Yeah. And can you treat me yet? And, so I think it might not be worth your while telling me that you found something.
But you'd still want me to tell you that you'd found something?
Yes, absolutely.
Okay, good. James?
This is a rather nice end to the panel because now I can say that I agree with my fellow panelists. And I consider this to be a triumph for philosophy because clearly after just sitting with me for an hour or so, they've been cured of a muddled thinking and poor reasoning, and now we're all on track. So I think that both Alain and Josie are exactly right, that there are really two issues here. There's the question of what should be disclosed to the patient given the testing that she was entering into, and also what should be disclosed to the patient given the incidental findings. And I think that Alan's approach is exactly right. It would be good to talk to patients beforehand and ask if there are anything incidental found, would you like to know about it? And maybe also be a little bit more fine-grained and outline some of the possibilities. Because some patients might like to know things if they could be potentially serious for their children, but would prefer to remain ignorant of things that might simply have effects on them long-term. So I think that Alan's approach is exactly right. People should be allowed both the right to know, to be informed. Medical professionals ought not deliberately withhold information from their parents, but patients should also be given the opportunity not to know about certain things if they wish not to know about them. And to maybe give a sort of more concrete example of this, I was once offered a visiting professorship somewhere, and it was appealing, but I didn't really want it all that much. And it was an American professorship, so of course the first thing that they said was, we've got a large salary for you. And I asked them not to tell me the salary, because I knew that if I realized just how high the salary would be, and admittedly in philosophy, high salaries in philosophy are different from high salaries in the medical field. So this is more like, we'll give you a day-old croissant every second day or something like that. And I didn't want to know what the salary was. I preferred to remain ignorant because I'd already made the decision that I thought was right. And I can see analogues in medicine where patients would prefer to remain ignorant of information simply because, as Jody said, it might actually adversely affect you even though it has no medical benefit at all.
Okay, thank you. Well, you all agree on this one. Thank you. Was there any comments from the audience? Roberta, did you?
My question is, what happened if the lady has a husband? What happened with the rights of the husband to know?
Oh, I say, right, okay. We're wandering into really dangerous territory now. I think it's her right to know rather than the husband's right to know, is what would be my opinion, but...
I agree with you. It's her medical history, it's her medical condition, it's her decision what she tells her husband.
Okay. Now, Siobhan, so let's hear, this is from the person who's actually been looking after this patient.
Yeah, so I'm actually very relieved, I suppose, by the panel's discussion. But
so your thinking wasn't muddled? It was.
No, my thinking was extremely muddled. I learned an awful lot from this case because it was, I guess, the first one of the research tests that have come through, which wasn't our own research test. So I think this opens up for me an entire can of worms that is going to become the bread and butter of immunology in the future.
Yeah.
So we are, I guess, in the luxurious position in London where there are multiple different research panels being done for different types of disorders. So this lady was sequenced not as part of one of our immunology panels, but as a panel for periodic fever syndromes by a colleague in rheumatology, as Bobby's pointed out. And then was referred directly to the immunology clinic with the question, this lady has a change in the Wiskott-Aldrich syndrome gene, please advise. And I think that things that I've learned from this are that when you have things that are done through a research panel, rather than referring the patient, it is better initially to go to a genetics panel, which is what we subsequently have done, and discuss the mutation with clinical geneticists before talking to the patient. And I think that if we had done that, we'd probably have, my thinking would have been less muddled initially. We also, I think, through, in terms of practically what can we do to work this out for this family, some of the things that happen with research panels are that the index case only is sequenced and the family is not sequenced. So in this case, knowing whether the dad carries the mutation and is unaffected and does not have Wiskott-Aldrich syndrome would be very helpful, and that's what we've decided to do next. So there's a lot of thinking that goes around, I think, trying to prepare for this type of patient coming to clinic that I think requires a multidisciplinary approach and genetics input.
Yeah.
But I think this is not going to be uncommon. So this is one lady. We have had another lady with a variant of unknown significance in NEMO, who is part of our immunology adult cohort, and who was sequenced as part of a research whole genome sequencing project. We have absolutely no idea what that variant of unknown significance means, except that it's very rare. I have a problem with discussing that with her. And in fact, I've been somewhat relieved of the dilemma in that case, because she also has DeGeorge, which has an impact for family planning in any case. And so she's decided not to have any children. But I think the rights of the individual to know their results, I of course agree with. The difficulty I have with it is that we are going to have so many variants that we don't know what to do with. So do we say to people who come into the immunology clinic, oh, we've got 1,000 variants in immune genes, we don't really know what any of them mean? I think that's not helpful, and I think we need to be less muddled in our thinking about what the science means and what the clinical impact is before we discuss these things with patients. And I think I personally learned a lot from this case.
Okay. Thank you, Siobhan. I'm going to ask for one quick comment back on that. What about all these other variants that we will find and are finding? How much of that should we disclose to families? James, do you want to, just as a last point, because we're going to have to stop pretty soon.
So I think that Siobhan's last point was actually extremely helpful and insightful, that if we have genetic information but we don't know what the clinical impact of it might be, it might not be helpful to actually inform the patient of this. And my thinking here is guided by considerations that Bruce raised in earlier cases concerning the autonomy of patients. And certainly within the United States and also within the United Kingdom, informed consent and patient autonomy are very, very important for medical ethics. Patients are expected to be involved in the direction of their treatment. They're expected to know things about their treatment. But I think that it's important to recognize that patient autonomy is about patients being able to direct their actions and make decisions in accordance with their values. Where there is actually information, medical information, but is relevant to their being able to do so. So if we have information about a person's genetic makeup, which we don't know the clinical implications of, then it's going to be information which is essentially not action guiding at all. It's just going to be, as it were, impotent information that might be given to a patient and really isn't going to affect how the patient guides and directs her own actions. So in those cases where we really don't know what the clinical implications are, I think that it would be perfectly reasonable to maybe inform the patient that all of the information has been retained, and if at some point in the future this becomes relevant to any medical decisions that they might make, then it will be given to them and disclosed. But at the moment, there's no point in them having it from a particular medical perspective.
Okay. All right. No, I think we're going to have to leave it there because we've got to call a halt to this session, and there's another symposium happening afterwards. So thank you all. Can we just thank all the panelists for their opinions? And thank you all for your participation. Thank you very much.
And also, just one final thing. I actually have a table out by the elevators because, philosophy is clearly as glamorous as all of the sponsors' booths. Because at the end of a session in Budapest, a lot of people actually wanted to ask me about ethical issues that they'd encountered. So I'm be parked outside by the escalators if anybody wants to come and talk to me later.
And if you haven't got any ethical issues and you've just got muddled thinking, you can come to James to sort that out as well.
But I should bear in mind that you'll be asking for advice from a man who thinks wearing heavy Scottish tweed in the middle of Dubai is a sensible thing to do. So it will be at your own risk.
Sorry.
So our thanks very much, Bobby, and to the panel. The discussion will continue, and we're about to shift to lunch and the poster walk. This room will be needed in 10 minutes because at 12:45, Biotest is sponsoring a symposium here. So if you could take your conversations quickly to the next spot so we can clear this room and begin that symposium on time. And thank you again to the panel.
Thank you.
Thank you.